Ladies and gentlemen, thank you for joining me. Chronic Disease and Depression Conference Call. Your host today is Mark Briles. And Mark, you may begin.
Good afternoon. Thank you, Chris. Good afternoon, and welcome to the Lake Superior Quality Innovation Network B1 and B2 Task Monthly Learning and Action Network event. That was a mouthful. My name is Mark Briles, and I will be your host today for today's webinar. And it's entitled Depression and Chronic Disease, Prevalence, Costs, and Intervention. And our speaker today will be Dr. John Briles, MD, Medical Director for Behavioral Health at Molina Healthcare of Michigan. Before I introduce Dr. Briles, I want to remind the Michigan social workers that are on the line, we're going to be offering one continuing education credit for participation in today's event through our partnership with St. John Providence Health System. I want to thank Michelle Malalam for her assistance in making the social work CEs possible. So at the end of the webinar, there will be an evaluation that will come up on the screen. That will be for everyone that's a non-Michigan social worker that wants CEs. The Michigan social workers, we're going to put a web link in the chat box that you will go to and do the evaluation and obtain your certificate. And I'll give instructions at the end on how to do that. So I'd like to now begin our program today by introducing our speaker, Dr. John Briles, Medical Director for Behavioral Health at Molina Healthcare of Michigan. Dr. Briles completed his medical school training at Wayne State University School of Medicine in 2006, and then he went on to complete a psychiatry residence at Henry Ford Hospital in 2009, and then a fellowship in child and adolescent psychiatry at Wayne State in 2011. Dr. Briles is board certified in adult and child and adolescent psychiatry, and he is also serving as our medical consultant for our recently awarded CMS-funded behavioral health project. Dr. Briles, when you're ready.
Okay, thank you very much for that introduction, Mark. Welcome, everyone, and thank you for attending. If I can get this moved. Okay. So, first of all, just to let you know, I can't identify any potential conflict of interest. We have several objectives for today. First, to discuss the importance of recognizing and addressing depression in patients with chronic disease, to discuss the prevalence of depression in diabetes, cardiac disease, and other chronic conditions, to discuss the overall disease burden and also the cost of healthcare in patients with chronic disease and depression together, and also to discuss some behavioral and pharmacological interventions that can assist in treating depression when associated with chronic disease. So, why is this even important? Well, aside from major depression as a disorder itself and its prevalence overall, it is more prevalent in the medically ill. We know that depression can intensify physical symptoms associated with medical chronic disease, in particular pain symptoms, and vice versa. So the worse the physical symptoms and pain symptoms are, the worse depression symptoms can be. We know that depression can impair cognitive functioning, including memory, which is important because when you think about that, if a person's memory is impaired, they're going to have a great deal of difficulty following treatment regimens and taking medications on schedule. Depression, we know, is also associated with several negative behaviors, potentially. For example, smoking cigarettes, drinking alcohol, or using other substances, including taking prescription medications more than prescribed. Poor diet. It can be poor food choices, but also eating too much or not eating enough. Inadequate or no exercise at all. And also social isolation, so withdrawing from your support systems, from your family, from your friends, from your hobbies, from work. I wanted to share with you a quote from the World Health Organization. This is from the World Health Survey. Depression produces the greatest decrement in health compared with the chronic diseases angina, arthritis, asthma, and diabetes. The comorbid state of depression incrementally worsens health compared with depression alone. With any of the chronic diseases alone, and with any combination of chronic diseases without depression. So a combination of asthma and diabetes will not be as impairing as depression and diabetes, or depression and asthma. These results indicate the urgency of addressing depression as a public health priority to reduce disease burden and disability, and to improve the overall health of the population. So, how does depression even develop? Well, aside from the obvious genetics and environmental factors, depression may also result from specific biologic or physiologic effects of medical illness. The best examples are certain central nervous system disorders, for example, Parkinson's, cerebrovascular disease, or stroke, MS, and certain endocrine disorders like hypothyroidism. Also, depression may be mediated by behavioral mechanisms. So, the limitations on activity imposed by a physical illness may lead to gradual withdrawal from rewarding activities, like I just mentioned, withdrawal from support systems, from family, from friends, from usual activities. Depression has also been linked to increased disease-related morbidity and mortality. We know that depression is clearly associated with a poor prognosis and also more rapid progression of chronic illnesses, including the ones we're going to talk about in more detail today, ischemic heart disease and diabetes. Depression may also affect the course of ischemic heart disease, specifically through a physiologic process by increasing platelet activation, or diabetes through decreased glucose tolerance. Randomized trials have shown the efficacy of both pharmacologic and psychosocial treatments of depression across a range of chronic medical conditions, and we will certainly get into more details as we get more into the presentation today. I wanted to share with you a little bit about the overall economic burden of depression. I will tell you that I tried to find more specific dollar amounts in terms of depression associated with chronic illness, but this is for depression in general. Looking at people in this country suffering from depression, the economic burden reached $210.5 billion in 2010, which interestingly was a 21% rise from the $173.2 billion in 2005. It's estimated that about half of this total amount is due to overall workplace costs, so absenteeism or decreased work production. About 45% is attributable to direct costs and 5% to suicide-related costs. Prevalence of major depressive disorder in the U.S. was 13.8 million people in 2005, which rose to 15.4 million in 2010. And very interestingly, the age bracket that this seems to have impacted the most are people aged 50 or older. Now, I'm just speculating here, but we also went through a pretty significant economic recession during that time period, and so I suspect that had a lot to do with this, especially if you look at the age range. We're talking about people who are near retirement age or are in retirement. Multiple studies have shown that depression is associated with increased costs in every cost component across the healthcare spectrum. So this includes primary care, pharmacy, medical specialties, emergency and urgent care, lab costs, inpatient medical costs, and of course, obviously, inpatient, outpatient mental health. But only about 10% is actually due to mental health utilization. The rest of the cost is medical care. When compared with usual care, collaborative care interventions appear to be associated with trends for decrease in every cost component across the board. And towards the end of the presentation today, I'll share with you a collaborative care model, and we can talk more about that during questions and answers if you'd like to. Coexistence of major depression with chronic conditions, to sort of reiterate what was just said, is associated with more ambulatory care visits and emergency department visits, but also very importantly, total days spent in bed because of a physical illness, and also overall functional disability. So as a starting point, the prevalence of depression in primary care patients is estimated to be about 5 to 10%, which, by the way, is pretty consistent with the prevalence in the general population. Prevalence rates of depression in patients with diabetes, however, estimated to be 12 to 18%, so about double that. And in patients with coronary heart disease, estimated to be 15 to 23%, so about 3 times that. So some important points that especially those of you that practice in primary care settings will hopefully appreciate. First of all, the presence of chronic medical illness may actually reduce the likelihood that healthcare providers recognize or treat depression, and there are several explanations for that. The demands of chronic illness management and thereby multiple competing demands may leave inadequate time to evaluate and treat depression during and I'll throw this in there, an 8-minute office visit. So a person that presents with 5 chronic medical conditions and one of them has an acute exacerbation, it can be very challenging to evaluate and then treat depression during that office visit. And then, even when symptoms of depression are recognized, sometimes treatment is deferred because some providers will think, well, gosh, anyone would be depressed in this situation. A patient who's obese, smoking cigarettes a day, diabetes is out of control, they just survived their second myocardial infarction. Yeah, of course they're going to be depressed. But we need to be careful of that, and we really need to change that thinking because actually some patients in this situation may not be depressed at all. Some may be a little depressed. Some may be quite depressed but not meet major depression criteria. And some may actually meet criteria for major depressive disorder, and treatment of depression may be appropriate. Because symptoms of depression, for example, fatigue or changes in appetite, may overlap with manifestations of medical illness, it's important to consider that using standard screening tools or diagnostic criteria for depression could actually lead to an overdiagnosis of depression. But I would also add to that when unsure, it is appropriate to refer to a behavioral health specialist to evaluate, because sometimes you have to go into more detail to understand, well, if it's more a cluster of depressive symptoms that are associated with medical illness, well, maybe it's not actually major depression that's occurring, and so sometimes it takes extra time and more expertise to sort through that. And also to rule out other potential conditions or explanations for the symptoms. Primary care physicians rate patients with depression as more difficult to evaluate and treat compared with patients without depression, and I don't think that's any surprise to anyone, certainly not a surprise to me. Patients with depression make about twice as many healthcare visits, and often for vague physical symptoms, but also tend to miss more visits. Again, not surprising. Remember, people with depression are more likely to have physical symptoms or worse physical symptoms. And depression affects cognition, including memory. So a patient with depression may be more likely to forget a visit, or perhaps the depression is so severe they can't get out of bed, or can't even pick up the phone to call and cancel an appointment. Compared with non-depressed controls, patients with depression are also less satisfied overall with primary care providers and the care that is provided. Again, this is not surprising. One of the hallmarks of major depressive disorder is anhedonia, or a loss of interest, or a loss of pleasure in things. And so, in general, a depressed patient is likely going to be less satisfied with a lot of things in their life, including the health care that they're provided with. So moving on, we're going to get into a little more specifics about diabetes and also patients with cardiovascular disease. As I mentioned, depression is about twice as prevalent among persons with diabetes than those without depression. Factors associated with low socioeconomic status may contribute to development of diabetes among persons with substantial depressive symptoms. This is interesting to think about, and I don't think very surprising. So a patient who already has depressive symptoms or history of major depressive disorder, also in a low socioeconomic situation, thinking about the fact that depression can lead to several negative behaviors that I mentioned earlier, being in a lower socioeconomic status, especially around this area, a person in this situation may not have appropriate transportation or access to healthy foods. They may not have access to a grocery store or be able to purchase healthy foods at all. And all the other things that go along with low socioeconomic status and the common psychosocial barriers that we see. Total health expenditures for persons with diabetes and depression are estimated to be 4.5 times more for those without depression. So that is significant. Despite availability of measures to screen for depression, it's estimated that actually less than 25% of patients with depression are diagnosed and treated. Research has revealed that both CBT, that's cognitive behavioral therapy, and antidepressant pharmacotherapy are associated with decreased severity of depression, improved treatment adherence, and also, importantly, improved glycemic control in patients with diabetes. I wanted to share with you a little bit about some treatments, starting with the antidepressants. Both sertraline, which is Zoloft, and fluoxetine, which is Prozac, have shown to be effective in studies. But be cautious of things like weight gain, which in general tends to be mild with these antidepressants, but also sexual dysfunction as a side effect. And as we know, patients with diabetes often have problems with sexual function. Also be mindful of drug-drug interactions with a patient's diabetes medications. Please make use of your electronic medical records, your online resources, your phone applications to be doing drug-drug interaction checks. These other medications I have here don't really have the studies to back them up. This is more thinking about it logically and from an intuitive sense. Bupropion or Wellbutrin. It is more weight neutral than the SSRIs, has less sexual side effects. Also, bupropion is marketed as Zyban for smoking cessation. And we know that smoking cigarettes is definitely more prevalent in this population. And also possibly bupropion may be helpful for neuropathic pain. Also effective for neuropathic pain are venlafaxine or Effexor, and duloxetine or Cymbalta. So these are all good considerations. Moving on to cardiovascular disease, remember that it's estimated that the prevalence of major depression in patients with cardiovascular disease is about 3 times higher than the general population. And meta-analyses have revealed that relative risk for developing heart disease in individuals that have depression or depressive symptoms is about 1.6 times higher than those without depression. So that is significant. Persons with a history of major depression are greater than 4 times as likely to have a myocardial infarction than those with no history. Approximately 1 in 6 persons with history of MI suffer from major depression, and at least twice that many experience significant depressive symptoms if they don't meet the 4 criteria. Also, greater than half of patients report depressive symptoms within 18 months of having a stroke, so very significant. Heart health is impaired directly by negative effects that depression has on things like stress hormones, blood sugar, LDL cholesterol, blood pressure, inflammation, and sleep, and as I mentioned earlier, platelet activity as well. The use of the specific class of antidepressant medications, the SSRIs, which we've talked about already, may, in addition to their beneficial effect on depression, also exert an antiplatelet effect, which could also be protective against an MI. A combination of CBT, or cognitive behavioral therapy, with an SSRI doesn't seem to be, or at least shown to be most effective in treating depression in persons with cardiovascular disease. I wanted to talk a little bit about some screening tools for depression. Now, we're still on cardiovascular disease, but this is for patients in general also. The PH2 is a brief screening tool and should be considered a first step. It asks 2 questions. One about the frequency of depressed mood or feeling down, depressed, or hopeless, and also anhedonia. Again, that's little interest or pleasure in doing things. And this is over the past 2 weeks. Most people will agree that a total score of 3 or more out of a total 6 should warrant further investigation. And that further investigation may be the second step of using the PH2-9, which includes those above 2 questions, and an additional 7 more about sleep, having little energy, increased or decreased appetite, feeling bad about oneself, poor concentration, hypo or hyperactivity, and then suicidal thoughts or ideation. And by the way, these questions are consistent with the DSM criteria. PH2-9 also includes a 10th question asking how difficult these problems have been. This can help arrive at a definite diagnosis, but of course along with an appropriate clinical interview, assessing the degree of impairment, which is very important, and ruling out other potential causes of symptoms. And this includes trying to sort through what are symptoms of major depression and what could be physical symptoms of the chronic illness. Moving on to treatment in this population for patients with cardiovascular disease, there have been randomized controlled trials that have demonstrated that 2 of the SSRIs, sertraline or Zoloft, so again there's Zoloft, and citalopram or Celexa, appear to be safe for patients with cardiovascular disease and are effective for moderate and severe depression as well as recurrent depression. SSRI treatment soon after an MI appears to be safe, is relatively inexpensive, and appears to be effective for post-MI depression. Also important is that patients with recurrent depression who have previously been on an antidepressant medication, have responded well, tolerated well, really should resume taking that medication, unless, of course, it's now contraindicated. For example, the older tricyclic antidepressants and monoamine oxidase inhibitors are contraindicated for many patients with heart disease because of their cardiotoxic side effects. But other SSRIs or SNRIs may be appropriate if they've had success in the past. I wanted to briefly define cognitive behavioral therapy for those of you that are not familiar with this form of treatment. CBT is a kind of psychotherapy that is focused on the present. It's more time-limited and more problem-solving oriented than the traditional forms of psychotherapy, including psychoanalysis and psychodynamic therapy. With this treatment, patients learn specific skills that involve identifying distorted thinking, helping to modify beliefs, helping patients to relate better and more positively with others in different ways, and hopefully eventually changing behaviors to making behaviors more positive. CBT helps patients identify distressing thoughts and helps them evaluate how realistic these thoughts are, and it helps them to learn to change the distorted thinking. The idea is that when patients think more realistically, they feel better. CBT should be at least 12 to 16 sessions over 12 weeks. This is advocated to achieve remission of moderate to severe depression. Although I will tell you, in the real world, CBT is generally spread out over longer time periods. If for no other reason, it's very difficult to see patients on a weekly basis. Also wanted to mention the importance of exercise, aerobic exercise and cardiac rehab for these patients. The prescription of exercise from a healthcare provider really needs to be individually assessed based on, of course, cardiac status and also exercise capacity of the patient. I would also throw in there the patient's willingness to participate in the program. Research has suggested that participating in 3 to 5 exercise sessions per week for 45 to 60 minutes per session is ideal. For aerobic exercise, it's recommended that achieving a heart rate of 50 to 85% of a patient's maximum heart rate is appropriate. And interestingly enough, the dropout rate from a program such as this is actually very comparable to rates in studies of dropouts with medications and also psychotherapy. Again, it's very important to have a discussion with your patients about what is appropriate for them and what they're willing to do. Following major coronary events, cardiac rehab is associated with both reductions in depressive symptoms and associated excess mortality. And it appears that only mild improvements in levels of fitness is what's needed. There was a 2002-2005 study of 522 coronary patients that showed that the prevalence of depressive symptoms decreased 63% following rehab, from 17% to 6%. And also that depressed patients who completed their rehab had a 73% lower mortality. That's 8% versus 30% compared with those that did not. I also wanted to share with you a collaborative care model, and there are different collaborative care models out there, but to give you an idea of what this looks like and what it can do for patients. So this is a 2007 to 2009 study in 14 separate primary care clinics in Washington State. Patients were identified using the EMR that had diabetes, coronary heart disease, or both. They used the PHQ-2 by mail or phone, and a total score of 3 or more out of 6, which is consistent with what I mentioned earlier, then completed the PHQ-9 by phone. The total score on the PHQ-9 is 27, so a score of 10 or more in this study, 10 or more is generally considered to be moderate depression. We're eligible for this. 214 patients were enrolled. This is a 12-month intervention that was aimed to manage depression, improve glycemic, blood pressure, and lipid control by integrating a treat-to-target program for diabetes and coronary heart disease with a collaborative care for depression. This intervention combines support for self-care with pharmacotherapy to control depression, hyperglycemia, hypertension, and hyperlipidemia. First-line agents included were diuretics and ACE inhibitors for hypertension, statins for hyperlipidemia, metformin for hyperglycemia, and citalopram or Celexa or sustained-release bupropion or Wellbutrin for depression. Nurses were used in this intervention, and nurses were trained and used motivational and encouraging coaching. Nurses also receive weekly supervision with a psychiatrist, primary care physician, and psychologist to review new cases and also patient progress. Patients receive self-care materials, including videos, booklets, and self-monitoring devices. So, looking at the results of this intervention, at 12 months, patients in the intervention group, so 37%, were more likely than patients who received care as usual, as 22%, to meet the guideline criteria or achieve clinically significant improvement from baseline values for control of glycated hemoglobin, LDL cholesterol, and systolic blood pressure, and also there was a significant reduction in SDL-20 depression scores. Also, patients in the intervention group were more satisfied than controls with care received from both medical and psychological disorders. And I touched upon that briefly earlier. Satisfaction with care also predicts enhanced self-care and certainly more favorable outcomes. Okay, so in summary, we've discussed several things today. First of all, the importance of recognizing and addressing depression in patients with chronic disease. We discussed the prevalence of depression and diabetes, cardiac disease, and some other chronic conditions. We discussed the overall disease burden and cost of healthcare in patients with chronic disease and depression. And then finally we discussed some behavioral and pharmacological interventions, including a collaborative care model that can assist in treating patients with chronic disease and depression. So with that, I'd like to turn it over to Mark again, and we'll open it up to questions and answers. I want to thank you again for attending today.
Thank you very much, John, for that excellent presentation. Chris, can you tell the participants how they can ask a question through the phone line?
Yes, I sure can. Okay, ladies and gentlemen, if you have any questions at this time, please press the number 1 key on your phone. And again, if you have any questions, please press the number 1 key on your phone. Our first question is from Jennifer with the Mayo Clinic. Please go ahead, Jennifer.
I'm curious if the gentleman who's doing this was part of the COMPASS program.
No, I was not. Actually reading looking at the chat here. I'm not familiar with this project.
You should look it up.
I should.
It is absolutely exactly what you're talking about. We did a 3-year grant through Medicare and Medicaid, and I know Washington was involved as well. Okay. And we took care of patients that had to have depression and chronic illness, specifically either cardiac disease or cardiovascular disease or diabetes. And we had great outcomes. It ended in June of this year, and we had really excellent outcomes with our patients. I will say that some of the things we found for sure was that if you don't deal with their depression first, you're much less likely to get their chronic illnesses in control. Absolutely. And the other thing I would say is that we found, without a doubt, you need to have a social worker involved.
And that's an important point. That also depends on what population you're serving. Without a doubt, if you're working with populations where there are significant psychosocial issues and barriers, then absolutely. We know that patients, the way they prioritize things, they tend to put their health care down the list when they're dealing with housing issues or family problems, or the list goes on and on. I appreciate that feedback. I will definitely look that up.
Hey, thanks.
Our next question is from Kristen with the Henry Ford Center. Kristen, please go ahead. Please go ahead, Kristen. Our next question is from Barbara with the Fairfield Physicians and Associates. Barbara, please go ahead.
Yes, thank you for entertaining the questions. I'm calling about specifically with your background with type 1 diabetes in pediatric population, and it seems it's harder to kind of pull apart depression in children and adolescents, and I know some primary care practices are starting to embed social workers or behavioral health consultants along with primary care, and I'm wondering if you could speak to any of your experience with this population.
I'll be honest, I haven't had a lot of direct experience with that specific population.
Okay.
I can start by saying this. There are, in terms of, if we're going to talk specifically about depression in this population and pediatric patients with type 1 diabetes, there are actually a modified version of at least the PHQ-9, I'm not sure about the PHQ-2, for screening children and adolescents for depression. Again, the importance of having access to a social worker, and again, depending on where you're practicing, but that's definitely going to be important because, as everybody knows, it can be a very difficult condition to manage, very difficult for children and adolescents to comply with treatment, and they really need the extra support and resources. So I appreciate you bringing that up. Do you have any other specific questions about that population?
No, not at this time.
Built about 2 years ago.
I'm sorry? Thank you, Barbara.
Thank you.
Do we have any further questions? If you have any questions, please press the number 1 key on your phone. Again, if you have any further questions, please press the number 1 key on your phone.
Hey, John, this is Mark, and since we're waiting for additional questions, I did have one. I actually have a couple. In your opinion, and you and I have worked together before, and I know you feel strongly on this, but I want you to share with our listeners, why is it important to screen for depression at the primary care level?
Well, thanks, Mark. There's a lot of reasons for that. As we know, primary care clinics really are the gateway to most forms of treatment. That's really where things start. As I mentioned, major depression is missed a lot. Only about 25% of patients get properly screened, diagnosed, and referred. So a lot of it is missed. And so it really needs to start in the primary care setting. And that's, that goes for all patient populations. I would say, just based on what I've been talking about today, knowing that major depression is more common in chronic illness, including diabetes and cardiovascular disease, even more important to screen because it's more prevalent in these populations. And as was mentioned a few minutes ago, I lost my train of thought.
Screening in primary care.
Yeah. I was trying to think of the last question, a couple questions ago.
How about the adolescents?
No, one before that.
How about the COMPASS program?
Yeah. That's kind of what I was thinking of. That's okay.
Chris, are there any more questions? Because if not, I do have another one I'd like to ask Dr. Briles.
Yes, we do have one further question from Ebony with the Crystal Home Healthcare Center.
Very good.
Hi,
Ebony, go ahead.
Hi, thank you. Can you guys hear me?
Yes.
Okay. We have a maternal infant health program here at Crystal Home Healthcare. We service women who are pregnant and women who have infants under 12 months. The program's main function is to reduce infant mortality and morbidity. A lot of the moms come to us when they're pregnant and they suffer from depression, and not just our moms with postpartum, but while they're pregnant, they were diagnosed prior to even becoming pregnant, and some of them, have bipolar syndrome, schizophrenia, and a lot of other issues relative to depression. They can't take their medicine, and so our social workers and nurses work with them in their homes on different methods and different therapy interventions to try to combat that while they're pregnant. I wanted to know if you had any insight on various things that we could implement and assist them with while they're pregnant.
Mm-hmm.
Make sure they have a healthy pregnancy and a positive outcome, which is our main focus, because they can't take their medicine.
Well, and that's what I wanted to ask you about, Emily. When you say they can't take their medicine, what do you mean by that?
Based on some of the different medications, and I can't think of, we have so many different patients and so many different issues. Some of them are not taking their medicine. They don't want to interfere with their prenatal vitamins, and they don't, they won't take it while they're pregnant.
Okay.
And whatever their antidepressants are.
I would say this to start with, especially if we're talking about patients that have a moderate to severe mental illness, whether that be major depression, bipolar disorder, schizophrenia. If it's moderate to severe, they really should be seeing a psychiatrist, because a lot of the time, taking their medication during pregnancy as well as postpartum is usually good. The benefit of doing that will typically outweigh any risks. A lot of people forget that. A lot of people just kind of knee-jerk, I need to stop my medicine, I'm pregnant, or I'm going to be breastfeeding. But with the psychiatrist, the patient should be sitting down and having this discussion and weighing the risks and benefits.
Got it.
Okay, it's very, very important, because some of these conditions can be so impairing that the mental illness is going to be, much more impairing and risky to the overall health of the mother as well as the infant than any potential risk they could have. So, of course I'm biased because I'm a psychiatrist, but I think that's great.
I understand. That helps. We have mobile doctors here as well, so we may have to just refer them to one of our mobile doctors, and we do have psychiatrists.
But there aren't too many psychotropic medications that are absolutely contraindicated in pregnancy. Some of the mood stabilizers for bipolar disorder do have pretty significant risk to the fetus, but overall, generally pretty safe, and again, in most situations, the benefit's going to outweigh the risk.
Got it. Okay.
Yep.
Thank you.
Yep, you're welcome.
Hey, Chris and John, can I make one announcement before I have another question for you, John, but I do want to make an announcement that there is going to be an evaluation that's going to be coming up on the screen momentarily. It's already there. This evaluation is for everyone besides those who are seeking social work CEUs. I'm going to post a link or Gavin's going to do it right now, post a link for those that want Michigan social work CEUs to go to our website, complete the evaluation, and print a copy of their certificate. So any non-Michigan social workers, feel free to do the evaluation on the screen. Michigan social workers, please follow the link that Gavin is going to put on in the chat box right now. Okay? So just wanted to make that clear. John, I did have, or Chris, do we have any questions from the participants before I go forward with mine?
We have no further questions at this time.
Okay, thank you so much. John, I wanted to ask you about the use of atypical antipsychotics in treating MDD, major depressive disorder. I've worked with psychiatrists who've used those before, and I just wanted to get your opinion on that. Is this good? What are the benefits versus risks of using atypical antipsychotics?
That's a great question and very pertinent, because atypical antipsychotics are prescribed more and more. I would start by saying this. Atypical antipsychotics, and I'm talking about the ones that even have an FDA approval, are approved as an adjunctive treatment. So a patient should be on an antidepressant first and foremost, and then possibly an atypical antipsychotic, and it's adjunctive. So it's because the patient needs to have a little bit better response, or they haven't responded well enough to an antidepressant medication by itself in the past. Especially those practitioners that are not psychiatrists, I would say be especially cautious in prescribing atypical antipsychotics, because in general, side effects and risks are more substantial compared to just an antidepressant alone. In general, as a class, the atypical antipsychotics, you have to worry about metabolic type side effects, so increase in weight, problems with glucose, with lipids, and these are things that should be monitored regularly. And there's certainly guidelines that I could share if people are interested. I did share some guidelines a few weeks ago during my last presentation. But that's what I would say about that. And I certainly welcome any more specific questions if the audience has any.
Thanks, Dr. Briles. I appreciate that. Chris, do we have any more questions? Chris, do we have any more questions from the participants?
No, we have no further questions. Thank you.
Thank you very much. I think that at this point, if we don't have questions, I want to thank Dr. Briles for another outstanding presentation for us here today. And I did want to remind the listeners that we do have, it's kind of on a different topic, we do have an upcoming webinar on September 23rd at 12 noon, which is going to be an update on adult immunization. And Gavin's going to put a link for registration on in the chat room for that one. And I also want to remind everyone that's listening that we do have a new initiative at MPRO, and it's focused on behavioral health. And we're going to be working with in Michigan and Wisconsin and Minnesota, our partners in the LS2IN, to improve screening rates for depression and alcohol misuse in primary care. And there's also a component in that initiative that includes work with independent psychiatric facilities, or IPS as we call them, psychiatric units and freestanding psychiatric facilities, to help them improve 7 and 30-day follow-ups. And if there's anyone that's from Michigan or from Wisconsin or Minnesota that works in a primary care setting or in a psychiatric facility that would be interested in more information on this initiative, and Dr. Briles is our medical consultant on this project, so please email me at mloush@mpro.org. Just want to do a little shout out on that. And then finally, to remind everyone, for social work, Michigan Social Workers, Michigan only, to follow the link for to do the evaluation and get your certificate. And the rest of you can do the eval on the screen, and we appreciate you doing that because it gives us feedback and insight into how to improve our presentation. Thank you again, Dr. Briles. Thank you, Chris, from WebEx, and I think we're good to go at this point. Have a good afternoon, everyone.
Thank you, Mark. Thank you, Chris.
You're very welcome. Thank you.